start up with the lecture for today. And we're going to try to cover two units today. We'll start off with neuromuscular conditions, and then we'll move on to physical therapy in vascular and pulmonary conditions. Let me just make sure that this is all set up. Open share tray, desktop. All right, so we'll start off with one, and then we'll move forward. Okay, so let's start off with physical therapy for neuromuscular conditions. So again, if you guys remember back to the very first lesson in the lecture that we had, again, polio, it had a huge impact on the evolution of the field of physical therapy. And this is the main driver for the field to evolve and take off. After that, again, there were wars. Wars also ended up in contributing. So disorders of the nervous system, again, so when you look at neuromuscular, the term neuro means nerve, and then also muscular means muscle. So remember, muscles, skeletal muscles, they will only contract when stimulated by electrochemical impulses. And again, electrochemical impulses, they're driven by the activity of the neurons. Now, what are some of the causes for neuromuscular conditions? Well, a lot of it stem from vascular system, but again, trauma. For example, more commonly, type 2 diabetes may also lead to neuromuscular degenerative diseases. Tumors also may end up causing these problems, and again, a handful of degenerative diseases and disorders. Now, one of the most common disabilities and disorders that you're going to be working with in individuals are going to be those that are affected by a CVA or a cerebrovascular accident. So again, in the CVA, what's happening is there's an interruption of blood to the brain. So why could this be? Well, this interruption may be from a bleed that's in the body, perhaps one of the blood vessels within the brain, or a major blood vessel leading to the brain, leading blood to the brain. Other times it could just be a clot, and that clot could actually be within the brain, or it could be, again, a larger vessel being obstructed, a larger vessel supplying the brain that may be obstructed. And these could have implications, such as hemiparesis, where a certain part of the body may be weakened, or again, it could be paralyzed. So usually it tends to be on the side opposite to the lesion. So for example, if you have a left-sided CVA, in other words, if there's a clot or a bleed on the left side of the brain, therefore the right side of the body is going to get affected, because how our body works, God designed it this way. Now, initial recovery is about it's a slow process. Okay, so that initial recovery, even what we in the field consider to be rapid. In other words, during the first 3 months, you see the most changes that take place, the most positive changes. After that, it's much slower. It could take up to a year or beyond that. The changes that you see after the 3 months are rather slow. TBIs or traumatic brain injuries, the most common cause for this would be falls. And we tend to see this in young children and older adults the most. Again, this could result in cognitive impairments, emotional, and again, in the case of this picture, it's physical impairment as well. Spinal cord injuries or SCIs, One of the most common causes for this are motor vehicle collisions, MVCs. Again, they don't use accident anymore because, again, most of collisions that take place, they're not accidental. You know, they're due to neglect. And again, neglect is not an accident. So again, they change the term from motor vehicle accident to motor vehicle collision, MVC. And because accident, this would imply that you know, it was a mistake, when it's not really a mistake. It's driver error, driver fault. So that's one of the most common reasons. Remember, don't forget this. It's a very important point to remember. MVCs, motor vehicle collision, they result from driver fault, driver errors. So this is why the term is changed. It's not really an accident. Falls, violence, sports. Again, this could be from diving or playing from American football or any type of sport for that matter. Physical activity, very physical sports. Men, there are 4 times, okay? Men are 4 times more often than women are, okay? To develop spinal cord injuries, 4 times more common for men than for women. And the most common age group would be those in between the 16 to 30 year range. All right. So now, what types the results that we see from spinal cord injuries? Tetra and paraplegia. Essentially, you're paralyzed from the neck down. In other words, all 4 limbs are paralyzed. And paraplegia, that's usually could be just be the legs, or it could be, again, everything below the trunk. So at this point, you know, the goal, the aim is to focus on flexibility, strength, cardiorespiratory function, and again, other functional abilities. And what is working, you want to keep those stronger. There's also vestibular disorders. So again, when you're learning your anatomy, you recall that the semicircular canals within the ear, they are responsible for maintaining your balance, your proprioception. So there's these benign, proximal, positional vertigo, or BBPV, benign, proximal, positional vertigo. Essentially, this comes from these calcium crystals that start to fall into the semicircular canals, and then, you know, that just kind of offsets. You end up getting dizzy because of that, because again, the hair cells that are there, they end up getting stimulated, and then it kind of disorients you. So when you're doing your physical examination, you should look at the nature, onset, and the circumstances that may have provoked each one of these incidences. Again, as far as treatment goes, you're rather limited to, for example, balance retraining. You can do, again, repositioning maneuvers as well of the head. Multiple sclerosis, or MS, this could result from demyelination of the central nervous system. Again, it forms, we tend to see this in men and women from the ages of 15 all the way up to 45, most commonly. It's idiopathic in terms of, you know, what seems to trigger it. We don't really know about that. Again, it's idiopathic. One thing that they do know is that as you move further away from the equator, the rates, it starts to increase. And people with MS, they have periods of remission and exacerbation. In other words, certain times it flares up, and other times, you know, it's not there, it's quiet. The treatment as a physical therapist, what you're going to be focused upon is primarily, you know, maintaining their functional abilities. There's also Parkinson's. Parkinson's is another degenerative disorder, and this is where there's a deficiency of the neurotransmitter dopamine, which is made by, again, from your brain. And again, there's a lot of symptoms that are associated with Parkinson's. Among them is pinrolling. There's also rigidity. In other words, you know, you're not able to passively move your limbs very freely. And so, you know, what comes along with this would be slow movement. Okay, we call that bradykinesia. And treatment is generally focused towards enhancing motions that are that are possible that are able to, the individuals able to do. Moving along, there's Guillain-Barré syndrome, or GBS. This is an inflammatory disorder of the peripheral nerves at the spinal cord. They think that GBS ends up being triggered by a virus. There is usually muscle weakness that starts off in your legs, and it just kind of progresses from there. Unfortunately, it's a rapid. The cascading happens rather quickly, within two weeks. So it does the damage very fast. However, in terms of recovery, it's rather slow. It could take a year or more. There's also amyotrophic lateral sclerosis, or ALS. Another term for this would be Lou Gehrig's disease. Lou Gehrig, again, he's a football player, and they gave this name to him. It's an eponym that's used for this disorder, for amyotrophic lateral sclerosis. So again, this is another degenerative disorder. It happens very fast. Again, there's degeneration of motor neurons. Again, they don't know what the cause is, and it tends to hit men usually. And again, the median age is 50. There's fasciculation that occurs. It could be in the limbs, or again, it could be within the breathing muscles also, and swelling. Unfortunately, people, they die within 5 years when this develops, after this develops. Again, you just have to kind of keep these individuals comfortable and try to optimize what functional abilities they do have. Right, so what about examinations? What type of examinations do physical therapists do? Well, one of the most common things that a physical therapist will do, again, would be, it's not even listed here, would be x-rays that you would look at. Beyond x-rays, there's a tomography, computer tomography, CTs, CAT scans, or magnetic resonance imaging. Again, a CT uses a lot of radiation, whereas MRI, it uses magnets. So again, MRI may be safer than a CT. However, the type of tissues that are visualized, they do vary. Some tissue, they tend to appear they appear more enhanced in CT, whereas in MRIs, they work better with other type of other tissues. And angiography, that may also be one of the things. It's looking at blood vessels, lumbar puncture, electrodiagnostic tests such as EEGs, NCVs, or EMGs. They all may be utilized as well. And in terms of history, you look at family history also. Then you do systems review, of course, right? You're looking at everything from all 12 systems of the body, 11 systems, sorry. Then you move on to what we're looking at over here, which is a movement analysis, a functional test. So you want to observe what is the quality that this woman's moving by, okay? What's her speed? How smooth is she in her motions? And the amplitude as well as directions you should be observed. When moving on to cognition, how well are they able to reason? How well are they able to remember things? How well are they oriented? Can they pay attention? Can they focus? So this is what cognition, this is what you're going to be looking at when you're looking at cognition. Some people, they don't have the ability to speak, so they may suffer something called aphasia. Or again, receptive aphasia on the other hand. This is when they have difficulty understanding. Expressive, again, they're not able to speak, they can't speak. So again, expressive aphasia, they can't speak. Not being able to understand, take that information in that you're telling them, that would be receptive aphasia. You also look at the range of motion. You look at the motor control. So again, motor control, range of motion, ability. So when you're looking at motor control, what's their ability to move voluntarily? How strong are they? What's the strength level within the muscles? How about involuntary movement as well as the coordination ability? How well is that? Muscle tone, right? This is again, what's the inherent resistance to passive stretch? So again, if there's low tone, we say it's hypotonic. If it's high tone, we say it's hypertonic. So sensation and perception also, that's something else that you're going to be looking at. Again, sensation, this is just the ability to transmit nerve impulses to the brain, to the spinal cord and brain. Okay, that's sensation. Perception, now this is your ability to interpret it. Okay, that's the difference. Sensation, this is the actual physical movement of a nerve to be able to conduct that a nerve impulse, and therefore the nerve impulse to travel through the nerves to the spinal cord and to the brain. That's what sensation is. For you to understand what that means, that's perception. So unilateral spatial neglect. This is the inability to make sense of the sensory information from one side of the body. Okay, so that's where this unilateral term comes from. One second. All right, moving along. One is next one. Evaluation, diagnosis, and prognosis. All right, so it may take multiple sessions because of the complexity and nature of the condition. So and you're not going to fix people after seeing them one time. It could take several months to years, right? Just the complete evaluation of detailed. This includes, signs, symptoms, syndromes, or pathologic condition. You want to look at prognosis. Developing a prognosis, estimating the level of their improvements. You want to make a plan of care. You want to go over what their goals are. Again, you want to keep them realistic based on an individual. There's no one size fits all. Every, a broken arm. Right, so how a boy, a 12-year-old, 13-year-old, it's gonna recover will be very different from how an 18-year-old will, and how that 18-year-old, what that 18-year-old is going to do, it's going to be different from that of a 23-year-old, and then 20 to a 30-year-old, 30 to a 40, 40 to a 50, and on and on and on. So it's very different for every group. So again, you have to develop, you have to customize the approach to every individual. So motor control theories and approach. So this addresses how movement is organized and coordinated. Now, the theoretical basis of traditional approaches, they're not supported anymore. Proprioceptive neuromuscular facilitation, or PNF, proprioceptive neuromuscular facilitation. So what they're doing at this point, they end up giving resistance at multiple points. And again, these points that they'll apply resistance at multiple joints and to see what could be activated in terms of sensory input. Now, the Brunstrom approach is based on qualitative observations of post-stroke motor recovery and neurodevelopment treatment. So again, do not worry about this one. Neurodevelopment treatment, do not worry about this. All right, yeah, skip that one. Neuroplasticity and intervention design. So this is based on the ability for both brain and spinal cord to be able to repair itself, to remodel. So you can use task-specific training for that. And task-specific training essentially involves repeating things, being specific of actions. And also you look at intensity and direction throughout the recovery. Motor learning, this is permanent change in the ability to perform a certain skill. So there's different stages levels. So there's cognitive stage, this is when you learn what to do. It's associative stage, that's when you refine the movements. And the autonomous stage, that's when you actually develop the skill. Therapists, again, they're going to be manipulating the variables. So, you want to maybe practice a single task, or again, you want to mix things up by practicing different tasks. And again, no specific order. So every time they come in, you do different things, or again, even the same things, but again, randomly. More unpredictable, which could challenge the training a little bit more. You can also practice the part of the task versus whole. Also, you want to get, you want to get feedback also. Now, activity-based training. So this is constrained induced movement therapy, CIMT. So it constrains the use of the constrained use of lesser involved limbs. That's what you do. The limbs that are not involved as much, you tend to constrain them more. Most of the application to the patient's wrist and finger movements are done after the stroke. So when you look over here, this is locomotor training, where they end up using, again, in this case, this is a harness, an overhead harness. This individual is retraining to walk for God knows why. Maybe she had a broken bone, a broken hip, or it could be a stroke. We don't know. What we do know is that there's a risk that she's going to fall. So, whereas a walker is not enough, she's not as strong. So this harness ensures that if she should fall, this harness is going to hold her up. It's not going to let her hit the ground. Now, she may roll forward, but hopefully, again, her hand is going to be there so she doesn't end up knocking herself on her head. She doesn't end up getting any head injuries. Yeah, so again, and as she moves along, this entire thing moves along with it. So physical therapy intervention for patients with neurological condition, again, frequencies, they include, again, stretching and strength training is great. There's also electrical stimulation that could be done, and NEMUS, neuromuscular electrical stimulation. There's also functional electrical stimulation. And again, you have a lot of assistive devices that are out there. Again, try to get the patient and family to be your partners in their recovery. Get them involved. Right? This is very important. So educate the patient, educate the family member on the prognosis, on the disease, on the treatment course. All right. So this is it for this first part. For this. What else is there? What else is there? We have the next part is let's move along. Obada, you have a question, Obada. Obada, your question? Zina, hold on. Zina, you have a question? Zina?
Yes, sir.
Yes.
Sir, the slides are not working. We cannot see what you're talking. It's stopped on slide number 2.
Oh, okay. All right, no problem. It's being recorded, so you guys can play it back afterwards. Let me try to correct it for the next slides. Okay.
Okay, I also have a question.
Yes.
Yes, in slide number 13, when you were talking about like receptive aphasia and expressive aphasia,
Right,
are these like diseases?